Thank you. I'd like to thank SAGES for the opportunity to present our work. I have nothing to disclose. Laparoscopic adjustable gastric banding has been widely adopted since its inception, with over 300,000 procedures performed worldwide. Advantages include its ease of placement, its low perioperative morbidity and mortality, its reversibility, and its durable weight loss. However, compared to other bariatric procedures, it has a relatively high complication rate, with failure rates up to 40 to 50%, and the majority of these requiring operation. Indications for reoperation include surgical complications related to the band or the port, as well as inadequate weight loss. Once decision for surgery has been made, the options that are available to us include removal of the laparoscopic gastric band alone, laparoscopic gastric rebanding, or a revisional bariatric procedure such as Roux-en-Y gastric bypass. Thus, the objective of our study was to evaluate the incidence and outcomes of safety and efficacy of revisional weight loss surgery after laparoscopic adjustable gastric banding at our institution. A retrospective review was undertaken, and within the study period, we found 256 patients who had undergone laparoscopic gastric banding at our institution. The primary endpoints we were interested in included early and late complications, as well as change in body mass index and excess weight loss. Patients within our program have a regular follow-up of 1, 3, 6, and 12 months, and then yearly after that. Thus, within the study period, we identified 256 patients. 111 of these required reoperative intervention for an incidence of 43%. 61 patients successfully underwent conversion to a revisional weight loss surgery for a median follow-up time of 47 months since band placement. The indications for reintervention are listed in this table. 77 patients had problems related to the band. 16 patients had problems related to the port, and inadequate weight loss accounted for the remaining indications. The patient characteristics are listed here. And again, you see a similar patient group. Of note, the BMI prior to band placement is similar within all three groups. Patients required reoperation at approximately 22 months after their band placement and 37 months for revisional weight loss surgery. There was a statistical significant difference in change in BMI, with the revisional weight loss surgery group having the greatest effect. And similar trends were found for excess weight loss. 46 patients underwent revisional weight loss surgery in one stage, that is removal of the gastric band and the bariatric procedure in the same setting. 53 patients underwent a Roux-en-Y gastric bypass. 8 patients underwent a sleeve gastrectomy. There was no statistically significant difference between the operative characteristics, nor in the complication rate. The incidence of early complications were 18% and 20% for late complications. There was one death, and as well, 95% of revisional weight loss procedures were successfully completed laparoscopically. 2 patients had conversion to an open procedure due to adhesions, and 1 patient had the bariatric procedure aborted and only underwent the removal of the laparoscopic gastric band. The trajectory of BMI is shown here for revisional weight loss surgery. The mean change in BMI was a decrease of 8 kilograms per meter squared at a median follow-up of 12 months. Of note, 48% at time of follow-up had a BMI less than 33. And a similar trend is seen for excess weight loss. The mean excess weight loss was 47.5%, with 54% of patients having more than 50% excess weight loss at time of follow-up, which is considered a successful bariatric procedure. In conclusion, the incidence of reoperation after laparoscopic gastric band at our institution was 43%. Patients undergoing revisional weight loss surgery had a higher rate of complication than as compared to patients undergoing primary bariatric procedure. However, good symptom control and continued weight loss can be achieved in the short term. Thank you.
Open for questions. So I'm going to ask you, what were your criteria for determining that you're going to reoperate on patients? I saw for the symptoms, it seemed like dysphagia was a high percentage. Was that just simply symptomatic dysphagia? Was that related to prolapse?
So the majority of them were symptomatic dysphagia. There were a percentage of them that also had a prolapse as well.
Did you try just taking fluid out of the band?
Prior to reoperation, all of the bands are emptied, and we give a trial period of several months. It varies, but usually several months of an empty band, and then if the symptoms don't improve, we consider surgery at that time.
Between the gastric bypass and the sleeve gastrectomy, the conversion, how do you guys determine which patient was the best candidate for each?
Our preference is to perform a laparoscopic Roux-en-Y gastric bypass in these patients. Again, they undergo intensive nutritional counseling and undergo through the program. However, in the patients that we performed sleeves, these were patients that basically refused to undergo the Roux-en-Y gastric bypass and would only accept the sleeve. And we were willing to perform that procedure.
So this question?
Yeah, along the same vein, how did you decide whether to do it in a one-stage or two-stage revision?
Again, that's a good question. I think at the beginning of our experience, we performed it in 2 stages. A lot of these patients had dysphagia and dysmotility. We were uncertain how they would respond to just removing the gastric band. And as our experience increased, we felt more comfortable performing it in 1 stage.
So one more question.
Yeah.
So you mentioned that it was done in 2 stages, right? How did you guys assess the motility of the esophagus? Then to base the patient going to have his sleeve, which is a high pressure system, perhaps going to further dysphagia, versus the gastric bypass. And let's say your patient has esophageal dysmotility, had the band removal, and say, doctor, I want his sleeve.
Right. I think that's a good question. I don't think we did formal studies on all of the patients. Definitely for patients that were high risk of dysmotility, we did perform motility studies, but I would not say it was a routine practice.
Thank you. Thank you.
Thank you.